You're listening to In Your Pants with Dr. Susie G, the physiotherapist for your privates, helping you get in the know down below.
Hey guys, it's Dr. Susie G here, and welcome to another In Your Pants podcast. I'm so glad that you're here to join us today. On today's show, we're going all the way down under, talking about prostate health and how to keep it healthy with professor, author, and men's health physiotherapist Craig Allingham. After a successful career in high-performance sports science and medicine, including 4 Olympic Games as part of the Australian team medical support, Craig focused his skills on men's health. Sadly, this was prompted by his dad's death from prostate cancer and observing the lack of knowledge in how men can manage both the disease and the side effects of treatment. Craig developed a program for restoring continence and erectile activity for men following prostate surgery with the idea that these men were now pelvic floor athletes and need a high-performance program to achieve their goals. His book, Prostate Recovery, MAP, Men's Action Plan, has been a great resource for thousands of men in Australia and overseas. In response to the trend towards active surveillance, which is deferring treatment for low-risk prostate cancers, Craig identified a group of men who are well monitored but not advised on how to reduce the chances of their prostate cancer progressing. His new book, The Prostate Playbook, is a strategic guide for men to suppress, undermine, and sabotage their existing prostate disease, or better yet, reduce the chance of having cancer in the first place. So we have a jam-packed episode for you guys here, and what you'll learn on today's episode is a few things, actually. The role of the prostate and how it functions, what are some curative treatment options for prostate cancer. You'll learn about some of the complications that may occur with curative treatments, what to expect with your recovery post-prostate surgery, the importance of pelvic floor physical therapy pre- and post-prostate surgery. You'll learn ways to train your pelvic muscles to help with continence control. You'll learn about active surveillance for prostate cancer, how you can sabotage prostate cancer and stack the decks in your favor. You'll learn about the effects of stress, diet, lifestyle on your prostate health, and how frequent ejaculation influences prostate health. I know that I get that question asked a lot, and we will definitely be covering it in today's show. So I hope you enjoy today's episode. I'm so glad you're here again, and let's get to it. Hi, Craig. Thank you so much for being on the show today.
Susie, it's an absolute pleasure, and thank you for the invitation.
No problem. I mean, it's all the way from Australia.
As you can tell from my accent, yes, all the way from Australia, where it's a beautiful, probably 28 degrees here at 8 o'clock in the morning, and you're in a polar vortex.
I am not as bad as my friends in the Midwest, Chicago area, Wisconsin, yes. Michigan. I'm in Asheville, so the temperature is a little bit milder, but nonetheless not sunny and shining, and, I'm not wearing my flip-flops. Well, very good. Well, today's show is all about the prostate, the penis, the testicles, men's health. And I kind of want to just start off the bat with having you tell us what are some of the common issues that men face after prostate cancer?
Well, many. But before we get to that, let's revisit what the prostate gland is actually there for. Because in my experience, a lot of men have no idea, one, that they've got one until it kicks up a fuss, and secondly, what its actual role is. And a lot of the pelvic physios I talk to, who are brilliant women's health physios who've come across and now embrace this new field of men's health, pelvic health, don't actually know what it does. They know where it is. They know it's the size of a walnut, but it's a curious beast. It's an exogenous gland as opposed to an endo gland. So that means it secretes a fluid via a duct to an external exit point. So what it makes is for delivery externally to the body, and obviously that's going to be the semen. And it is just a vehicle. It's a nutritional substance. So the testicles will manufacture the sperm. The sperm are then lodged in the epididymis of the testicle, where it is an acidic environment which keeps them inactive. and then they are gradually migrated to the seminal, through the vas deferens up through towards the seminal vesicles, and the seminal vesicles contribute some seminal fluid as well. And finally, it gets in through the ejaculatory duct into the prostate. So it's a long manufacturing, storage, logistics exercise just to get these tadpoles into the delivery gate. And there they wait for their moment of glory when they are delivered via the external duct with the seminal fluid. Now, the seminal fluid provides two things: one, a liquid environment for the tadpoles to navigate in, and secondly, a nutritional substance that they can absorb nutrition as they go, because it takes some time. And these little sperm cells are not particularly big. They don't have a lot of onboard energy nutrition, so they need to refuel as they go. And the seminal fluid provides that. So it's a fabulous little thing. And so they get into the prostate gland, and then there is a process of and they can live in there for a short period of time, and then they start to not go toxic, but there's a use-by date. You don't want your genetic material to be stored for too long before it goes and starts to mix it with an egg. So there is an expectation that once it's there, it will be moved on fairly quickly. And as all young men discover one morning when they wake up, it's an automatic process. So with nocturnal emissions, and it's a bit of a surprise. So, but that process would continue if a man wasn't to be regularly emptying his prostate for recreational or functional reasons throughout his life. So nature, evolution, wherever you want to go with this, has got a system of moving it on and restocking, moving on, restocking. Good. The prostate gland itself is not just a gland, it's a muscular gland. Mm-hmm. It's a muscular gland with gates. So it's quite a complex structure. And the muscularity of the gland, the muscle fibers in are to pump the ejaculate, to pump the semen and the sperm cells actively into the male urethra for obviously transmission out through the meatus of the penis to fertilize an egg eventually on a perfect mission. So it's a muscular gland, and it's got a gate, and one of the gates, the critical gate, is at the back gate where the prostate joins with the bladder. And just prior to ejaculation, that gate is slammed shut so that any muscular pumping of the ejaculate is directed in a forward direction and none of it retrogrades back into the bladder. So ideally, that's how it all should work. But after treatment for prostate cancer, a lot of these things don't work so well as they used to do. And that is a big issue for many men. We have to say prostate cancer in its own right is not a big health problem. It's not fatal. It's when prostate cells leave the prostate gland and set up camp elsewhere in other organs and create a secondary tumour. Then it becomes life-threatening. So prostate cancer that stays within the gland and just bubbles away for many, many years and doesn't get particularly aggressive or large can be asymptomatic and certainly not create any health problems. And we'll maybe talk about that in the lower risk guys down the track. But the question you did ask me some time ago before I got distracted was, what problems do they have with prostate cancer? Well, they don't. They have the problems with the treatment. The side effects of curative treatment for prostate cancer. Now, curative treatment can include removal of the prostate gland, a radical prostatectomy, which can be done as an open procedure, as a laparoscopic procedure, or as a robotic-assisted laparoscopic procedure, an RALP, which is a little less, traumatic for the abdominal organs and the pelvic organs and the pelvic wall. But the end result is the prostate is removed. That creates a gap, and that gap has to be accommodated by pulling the bladder down and the urethra up to join the urine evacuation system back in place. You need that working from the bladder to the penis. You need to be able to get the urine out. So if you take the section of the urethra that is enclosed within the prostate gland, And there's a varying degree, even though the surgeons are trying to salvage as much of that as possible, and they're particularly trying to salvage the back gate of the prostate where it butts up against the bladder, because that's where the sphincter, the gate is, and it's also where there's some muscular control aspects, autonomic, which means unable to be voluntarily controlled by the man, but a muscular system there to control urine release as well. So they try and preserve that base of the prostate against the bladder and dissect out the remaining urethra and prostate together, and that goes to pathology for analysis. And now you've got to join the tubes again. So there's an anastomosis or a suture joint that goes in between pulling the outer part of the urethra up towards the bladder, drawing the bladder down, suturing that together, and then the guy gets a catheter put in so that there's a splint, if you like, an internal splint around which this wound can heal. That could last anywhere from 5 to 10 to 14 days, depending how things travel with him. So his prostate's gone, but his urinary system has been messed about with. So one of the major complications following prostate surgery is incontinence or lack of continent control. Maybe not total incontinence, but certainly episodes of being unable to control urine leakage. Other treatments apart from surgery would include radiotherapy, which can be external beam radiotherapy or internal insertion of radioactive beads into the prostate around the tumour site, which is brachytherapy, to slowly radiate and inhibit the prostate cancer growth. There can be other aspects of therapy, chemotherapy, particularly if the prostate cancer has already started to metastasize or spread or externalize beyond the margins of the prostate. Chemotherapy, which will expose the prostate tumor cells wherever they are in the body to the chemotoxin. Hormone therapy to damp down the testosterone driver. Testosterone that men produce from their testicles doesn't cause prostate cancer, but if you have a prostate cancer, it can drive it and feed it a bit. So reducing the testosterone production can help with that, against suppressing the growth of the prostate tumour. And the newest field, of course, is immunotherapy, where the genetic code of the man is looked at and related to his immunosuppression strategies that his body prefers. And in the future, we're going to see a huge amount of development in this immunotherapy for all cancers. And that will be quite exciting, I think, because it will be custom-tailored treatment for each man's genetic predisposition to prostate cancer. So that's still a few years away, but it's going to be a very exciting time for men who have prostate cancer and sons of men who have prostate cancer, who will probably be the main beneficiaries at this time frame. So that's incontinence. Not so bad with radiotherapy. Brachytherapy, certainly not. Chemotherapy doesn't cause incontinence, and the hormone therapy doesn't interfere with continence, but they have other side effects as well. Feminization due to the hormone therapy issue, mood swings, temperature regulation issues for the guys, which you might say, yes, but you haven't got cancer anymore. No, but these things are quite unpleasant and unexpected, and I'll tell you why they're unexpected in a moment. The other big side effect that impacts on men far more than most of them anticipate is erectile dysfunction. Now, I'm sure you've talked about this in your podcast before.
I had Joe Milios on the show.
Oh, Joe talked about it. Yeah, Joe. Yes, yeah, excellent. Joe did that. So that's fabulous. And that's a huge area for men because they don't listen. They don't listen. That's not true.
Tell me more. Wait a second. My husband would disagree.
Well, yes, they don't listen, but sometimes they don't even hear. But let me put this to you. Here's a man. He's had his PSA done. He's had his digital rectal examination done. He may even had a biopsy done, and he's come into the urologist's office, and the urologist says, "I'm sorry, sir, you have got a cancer in your prostate." And it is a Gleason score of 3/4 = 7, and your PSA is 20.3. And in my experience, this needs to be removed, and the likelihood we need to do that in the next month or so to get it early. And you will need to have a month off work, and you will probably have a period of incontinence following the catheter removal, and you'll most definitely have erectile dysfunction and may not be able to get another erection for the rest of your life after this cancer removal, and you may have some fatigue and depression issues. He doesn't hear any of that bit after the word cancer.
Right.
You have got a cancer in your prostate. Well, that rocks his world, okay, because no matter what the earlier tests and indications might have suggested, every man goes into that final meeting with his urologist thinking it'll happen to some other bloke. It won't be me. I'll be fine. This is just an enlarged prostate. This is just an anomaly in the pathology results. But when they finally get that positive diagnosis that they cannot ignore or argue about, everything after that, everything that the urologist's lips are still moving, but there's not a lot getting through. Mm-hmm. And yes, there is informed discussion, but it's often a one-way thing, that the guy's just not taking it all in, because the most important thing in his mind at the moment is, I've got cancer. Cancer kills people. I need to have this cancer cut out of my body. Everything else is subordinate to that. And that works great until he's had the treatment. And then he hasn't got cancer in his mind. The first PSA test comes back at 3 months at, 0.01 undetectable PSA. He thinks he's cured. That's fabulous. His wife is happy. The kids are happy. Everyone's happy. But he's still incontinent and he still has erectile dysfunction. And he might only be 58 years old or 53 years old or 80 years old. Doesn't matter. If he had erectile function before, he will miss it. And this is a huge shock. The third side effect that I see most commonly is depression. And imagine one day you are completely continent, have fabulous, fabulous erectile function. 2 weeks later, you're incontinent and have zero prospects of erectile function for the rest of your life. Any man who doesn't get depressed with that is a Superman, or he's got some fabulous coping strategy I haven't learned about. So these huge changes to quality of life, and this has been documented in the research, quality of life questionnaires and validated, reliable for men after prostate cancer treatment show a significant decrease in their reported quality of life for the rest of their life. So there is a huge cost to treating your prostate cancer, particularly with surgery, but radiotherapy, bowel damage, burning, scarring, feminization from the hormone therapy, each of them has got a risk, a side effect. There's no perfect gold standard, do no harm removal of prostate cancer yet. I hope to live to see it in my day, but it's not there yet. Mm-hmm.
Right.
So they're the problems. Gosh, that was a long discussion. We've only covered the problems.
That's okay. That's okay. So based on all of that, that sounds like very doom and gloom. What should men expect during their recovery post-surgery?
All right. They should expect it to be difficult, and they should expect that they have to work at it. And I think that's the most important message we can give them pre-op, is that this is going to be the biggest challenge you've ever faced, not just health-wise, but lots of things. Your relationship issues, your ability to work, the cost, the financial cost of the time out of the workplace and stage recovery, the financial cost of incontinence pads, unexpected. Every month, another $30, $40 that wasn't budgeted for, bang, on the continence pads. How long is this going to go on for? Can't tell you. Some men permanently, some men none at all. I had a guy, one of my patients, and he's like, how we can make this happen every time. He was a younger fellow, got diagnosed, and he had the catheter removed and went home and had sex with his girlfriend that night quite successfully. No leaking, no erectile dysfunction, nothing. I said, well, you have got a good surgeon. And he said, no, I've got a good girlfriend. Well, that's true. So the range of outcomes is huge, and other men are not going to achieve that sort of outcome. And It's
so
not
Craig, so what you're saying is that there's perhaps no pattern or no rhyme or reason. There are some factors that might predispose one to having great success, and other factors based on the individual and the context of it all, not as great success.
Well, that is exactly true. And the urological surgeons will tell you that they go in, every operation adventure for them is a nerve-sparing expedition. This concept of I had nerve-sparing surgery. In other words, the nerves that run around the fibrous capsule of that envelop and constrict the prostate gland ultimately will be related to erectile function. So any damage to those nerves during the surgical procedure will at least temporarily and possibly permanently damage the capacity of the hydraulic system of the penis to become erect. But every surgeon goes in looking to spare those nerves, and it's so every surgery is as nerve sparing as possible. It's just not always possible. If the tumor is up against the nerve web, then the nerves will have to be sacrificed to ensure that the margins of the tumor are fully removed without any rogue prostate cells sort of escaping into the tissues.
Right.
So surgeons do a fabulous job, and they try to preserve the muscle and the sphincter and as much of that they'll leave as possible, but it's not always possible. And they don't know that. Even with ultrasound-guided MRIs and biopsies and everything, they still don't know exactly where the prostate cancer extends to and from until they look at it. Till they're in there dissecting, they think, okay, that whole thing's going to come out, but I've got to take this nerve. I can leave the one on the other side, or no, they've both got to go. Or I'd love to leave the sphincter at the bladder, but that's got to go too because it's up in the base of the prostate. So whatever. So they do the best they can every time because they want to get a good result. But those outcomes are beyond their control by the very nature of the disease. Yeah.
Right. And realistically, those surgeons will obviously communicate that to the patient saying, this is the situation, this is how much I was able to salvage, and this is what we needed to do. And these are the potential outcomes based on what I needed to do. Okay.
And by that stage, he's listening. He's getting all that on board now. He's got through the initial barrier. The cancer's been dealt with, and now he's ready for that second level of information. What I'm particularly interested in when I'm dealing with men, and this doesn't just apply to their pelvic health, post-prostate care, is how they process information from health professionals. And it's quite interesting how men receive this message. And if for any professionals that are watching this who work in men's health or treat men in any capacity, whether it's for sports injuries or occupational health or whatever, it's useful to put yourself in their place and say, this is, you think you're doing a fabulous communication job, but is it getting through? How do you make those messages stick? So I'm just going to, if that's okay, if we could just briefly run over this. This is the processing, and this is based on research that's been done on how messages are received by men in 2013 in a paper in Health Psychology. When men get incoming health information from you, from me, from the television, from their GP, from their physician, from whatever source, public health messages, whatever, the first thing they do is a risk assessment. And they do it on two levels. First of all, how severe does this sound? Okay, well, cancer's pretty severe. They've sort of got that bit. So they do a severity risk assessment. So if this is true, what I'm being told, how severe it is. So if it's a warning about sunburn, they think, oh, that's not so severe. So they filter that out to some degree. So that's the first risk assessment. Yeah, this is a really nasty condition. So prostate cancer rates for that. The second risk assessment they process is, it's really nasty, but is it really nasty for me? Am I susceptible? So they do a risk assessment on their personal susceptibility. And they don't do this at a cognitive level. They're not thinking, oh, how much is this going to affect me? It's the subliminal processing of this information coming through. For example, my dad died from prostate cancer, so I know I am really susceptible. Another man whose father, his family history has no prostate cancer in there, may know that prostate cancer is nasty, but it may not apply to him because there's no family history. Therefore, I'm not susceptible. Therefore, I no longer need to listen to health messages because I'm not susceptible. And you can see how this applies in nutrition, cardiac health, respiratory, smoking, messages, all this sort of stuff. People will find a way to find their out point. That doesn't apply to me. Every man believes he is the best driver on the. So how does that work? It's the risk assessment. So if he rejects the risk assessment, says either it's not severe enough for me to be concerned, or it doesn't really apply to me, he closes his filter. I call it the ego filter. I didn't make it up, but that's what I call it, the ego filter, to preserve his status quo, preserve his equilibrium in the world. I don't need to know about this stuff. I'm going to close my filter, and you can blather on all you like. It's nothing to do with me. And once the filter's closed, he'll have 3 coping strategies, one of which is denial. No, doesn't apply to me. Second one is avoidance. He doesn't expose himself to the messages anymore. The third one is withdrawal. He just goes into himself and doesn't process anything. You'll see this happen with your husband on many occasions.
I have, yes. I was just going to say you're reading my mind.
We can use it for all sorts of things.
Yeah, you're reading my mind. This is good. This is going to help me in my marriage.
This is entire global raising children that are boys, anything. So that's the risk assessment. But however, if the risk assessment scares the pants off him enough that it's nasty and he's susceptible, he's still listening. And he goes through a second filtering process on efficacy. The efficacy is the efficacy of the first stage, what's being recommended for treatment. So we'll stay with the prostate cancer story. I'm being recommended to have radiotherapy. That's great, doc. Now tell me, how likely is that to cure my cancer? Does it make sense? Do I understand the relationship between zapping my prostate tumor with radioactive waves and how that kills the cancer? That makes sense to my basic male science brain. So this efficacy of treatment sounds good. Cutting out the cancer, having a prostatectomy, that makes really good sense to me because the cancer is removed, because the prostate's removed and it's a prostate cancer. Goodbye. So the response is rated as highly efficacious, high efficacy. And then he screens it again to say, can I do it? What's my self-efficacy? What's my am I prepared to do 30 sessions of radiation? Can I take the time off work? Can I afford it? Is insurance going to cover it? There's a whole lot of other things going on. But can he, and maybe his immediate family unit, he's got the strength, the power, the skills. And again, this second filter of efficacy on the incoming health information, if he rates it very low, he says, the treatment makes no sense to me, or I don't think I can do that. I can't handle the incontinence or the erectile dysfunction, so it's not for me. Is there an option? He stops listening. Can we keep talking? Keep telling him, keep trying to convince him, but he's already filtered that out to preserve his psychological equilibrium and being comfortable with himself. However, if he is confident that what we're recommending for the treatment is likely to work, gives him a good option, and he has got the resources to do it, he's still listening. And the next level is action. When do we have it, doc? When do we start this pelvic floor training program? When do I improve my nutrition? Whatever it might be that's the recommended treatment plan, he's ready now. He's filtered and we've passed it. So when we're communicating health messages to men, we need to make sure we cover the severity. We don't talk it down. Oh, it's prostate cancer, and I see this in the forums of prostate cancer patients. Oh, some people say, oh, it's the lucky cancer. You can remove the prostate and it's gone. No.
Cancer.
This is a nasty
I've never heard
boy.
cancer as being lucky.
Oh, they write this, and the guys don't write it. It's partners or, I don't know, there is a lucky cancer, but you can just have it cut out. Oh, well, yeah, but there's some consequences.
Right.
When we're talking, we need to say, this is nasty. This is really you're going to have problems with continence, not play it down. So you're not, the 1 in 12 men have problems with continence. No, they don't. They all have a challenge with continence when the catheter comes out. Some have a rapid recovery, some have no recovery. Mm-hmm. Some respond really well to physiotherapy treatment, pelvic floor training. Some don't respond as well for a whole range of reasons. But I do notice that even they all get some benefit from it. Even the ones that don't become fully continent, they become less incontinent to some degree. So we can offer I'm always happy to say you're going to get some improvement, but I can't tell you how much yet when we're starting a program. And it will depend not only on the surgery, but how hard you work. throw it back to them, because we've got to get this self-efficacy. Mm-hmm. You're really going to have to drive this. You're going to have. I can't do your pelvic floor exercises for you. You have to. You're going to. Mine are good. I do them every day because I'm demonstrating, and nobody ever sees them. And I train myself. I'm bizarre. I go to bed at night. The last thing, of course, you do is you empty your bladder, and your bladder fills slowly overnight because of your serotonin release, and a whole lot of things change. So your kidneys work more slowly overnight. So you're designed to have a longer period of uninterrupted sleep because your bladder doesn't get as full as quickly overnight as it does through the day. So I test myself. So, okay, for the hour before bed, no going to the toilet, and I'm going to sleep through. I'm going to go 10 hours. Well, it kills me, but man, it's a good weightlifting exercise for your pelvic floor. Come getting out of bed in the morning, let me tell you. But
that's right.
I'm not advocating this.
Well, you're an Olympic. This is an Olympic bladder. I hear that you were an Olympian in your day.
An Olympic physio, yes, not a competitor. Olympic support crew, yeah. And it's exactly the same. It's a training program, because the pelvic floor muscles are muscles like any other muscle, any other skeletal muscle in the body, and they're trainable.
That's right. Well, tell us a little bit about that, Craig. What should a guy expect during physiotherapy, physical therapy? And is pre-rehab necessary, or does it help with the outcomes post-surgery?
In my experience, and from the research and from talking to colleagues, every time, yes. A pre-program, at least for 4 weeks, even up to 6 is enough. But 4 weeks, the last 4 weeks before surgery, if that guy can learn to do his pelvic floor exercises correctly, and that is to find the right muscles, to activate the right muscles at the right degree of intensity, and to do that frequently enough to create a training program, he can become a pelvic floor master in that time, and become quite proficient at isolating, and then not only isolating, but also isolating while he's talking, isolating while he's walking, these pelvic floor lift contractions. And the reason that we like to do it beforehand is because everything's normal. He's still continent. The pelvic floor muscles are operating. He may not be at all aware of them, but they must be in there doing something, because he's not leaking every day. So we've just got to find his voluntary connection, his mental connection to them, so he can train them. Because the next time when he comes back after surgery, everything's going to be a bit different. He won't have the sphincter muscles in the prostate gland anymore to help him out. He will be dependent on the 3 male pelvic floor muscles that he has voluntary control over to reinforce his continence control. So being able to teach him that when there's no pain from surgical incisions or internal things or complications from infections or catheter friction or anything else that sort of, because pain makes it hard to work a muscle in the painful area. We know that from all over the body. So being able to train him in a pain-free state, and to take a really positive view that this is not rehab. This is pre-season training. This is getting ready for the ball season or the football season. It starts on operation day, but you're in pre-season training. And guys get that analogy. You're in pre-season work. So this is your strength and conditioning phase. You need to work on this so that come game day, you're ready to play. So we like to work them through, and we work on the endurance long-term holds, up to 40, 50, 60-second holds while breathing, and also the rapid-fire contractions for the fast twitch fire. So we train all components of the male pelvic floor pre-operatively, and keep telling him this is for your continence, this is for your erectile function post-surgery, because he has no incentive to do these exercises yet, because he's fully continent and he has got erectile function. And that's important too, because one of the key indicators of the likelihood of having erectile function return after prostatectomy is the fact you had erectile function before the surgery. Mm-hmm. If you have, and there's a whole lot of reasons, cardiovascular, psychological, lack of opportunity, out of habit, whatever, diabetes, a lot of reasons why a man may not have erectile function. Well, having a prostatectomy is not going to cure that.
Right.
If you've
Let's
got
be
erectile
realistic.
dysfunction, let's be real. You're not suddenly going to wake up with a raging hard on and think, wow, I didn't expect that. And neither you should expect that. It's not going to happen. So erectile function, erectile activity is part of the pre-op program as well as training the pelvic floor muscles. So the message is to the man, and if his partner, if he or she is interested, you can get on board this as well. But the more you can exercise the organ, and it doesn't necessarily mean to full ejaculation, but just getting the erectile cycle refreshed and the hormone connections and the nerve connections all built in, and the arousal bit in the brain as well.
Which is so important. The main organ, right? Between the ears.
It is.
Men forget about that, I think.
It determines the success of every... well, they talk about the big brain and the little brain, and the big brain's the key one. Yes.
That's right. That's right. It's where all the magic happens.
It does, because even with, they all rely on arousal. You still need to be excited. Yes. Without that, what would be the point, really? So that's it.
So when should a fella start post-surgical rehab? When would it be safe to start doing some of these exercises?
Okay.
Yeah.
After the catheter is removed.
Okay, you said that could be 5 to 14 days.
Yep, it varies according to the surgical procedure and the challenge of the anastomosis, I think, at the surgical part of it. So that will be determined, and also how efficiently the catheter functions in place, how well the balloon blocks off so there's no leaking, there's no irritation of the wound site with the acidic urine leaking around it. So a lot of things can change that duration, but ideally, an infection would be one, ideally 10 days is about the norm. Could be a little more, could be a bit longer depending on the case. But but there's not much point working the pelvic floor because it will rub against the catheter. The internal urethra will be abrading against. So it's just asking for irritation, and you're not going to get full closure anyway because the catheter will splint the urethra open. So in terms of the specificity of training, we're not in the right length tension relationship. So, yes, it might be useful for the mental connect to refresh that engram, but we just say have 10 days off. You've got enough on your plate for a while.
That's
You've got a catheter, a bag, you're trying to work around the shower, you're trying to move around the house. There's a lot happening. I want to see you a couple of days after your catheter is removed.
Perfect. So
then we revisit. Yeah.
Great. So, Craig, tell us, you're currently working on another book called The Prostate Playbook. What should readers expect from this new book? Well, my first book, Prostate Recovery Map, is all about the pelvic floor retraining for guys after they've had surgery or any other treatment for their prostate cancer. So I feel like I've got that box ticked, but there's a lot more diagnosis of younger men with less aggressive prostate cancers now who have early stage, low volume, slow growing prostate cancer, PSA rising quite slow, not doubling in the 5-year double window, but still increasing. But it's not urgent that they receive any actual treatment. And they go into a program called active surveillance. And I was at the American Urological Association conference a year or so ago, and this active surveillance was talked about a lot by the urologists and the radiotherapists and the men's health physicians and everyone who was there on the podiums giving their papers. And they were all very, very good on the surveillance. They knew about the PHIs and the P2 tests and the PH tests and this test and that test, and they would, the biopsies and the ultrasound guided, focused, whatever's. Brilliant on all the surveillance, but none of them spoke about the active part. What can a guy do to suppress, to sabotage, undermine a prostate cancer he's already been diagnosed with that is a slow grower, that he may die with but not from? How can he stack the deck in favour of dying of a stroke or cardiovascular or killed by a jealous husband? So some other way of going, if he can find a way of suppressing or taking measures in his lifestyle decisions to suppress that, he has a better chance of avoiding treatment and therefore avoiding incontinence and erectile dysfunction and depression and all the side effects from the treatment, radiation burns, whatever. So it's about quality of life decisions, and if he is offered that just
deal with the active, the surveillance part, but he's got to take responsibility for the active. So this new book, the Prostate Playbook, covers 3 areas of lifestyle where he can stack his deck in his favour. So it covers managing stress to preserve your immune system efficiency. So we cover mindfulness training, we look at yoga, Tai Chi, various other ways of controlling the hassles in your life. And you've got a new one. You've just been diagnosed with cancer. That's going to be stressful. So how are you going to manage that? How are you going to take the emotion, take the energy away from cancer? And I really get, this is a personal thing, no research on this, but I hate this concept of fighting the cancer. Fighting takes energy. Fighting is like saying giving respect to your opponent. It's not. This is a parasite. It's just, you don't want it there, but don't give it the dignity of an opponent. Don't give it the dignity of a fight. Don't give any emotion to it at all. It's just something you are going to ride with now. It's something that's in you, that is part of you, and you are going to slowly sabotage it and stifle it by being smarter than it. You're going to outlast it. That's the goal, outlast prostate cancer. So mindfulness, mental stress relief. Secondly, nutrition, hugely important. Mm-hmm. There is ample evidence that adjusting your intake, your input of food and drink can make a huge difference. So moderate alcohol consumption. Coffee turns out to be good for us for prostate cancer. And some studies say, eight cups a day is fine, and it doesn't matter whether it's decaf or caffeinated, because it's not the caffeine that does the job. It's some other chemicals in coffee that actually help control prostate cancer growth. So enjoy your coffee. That's good news. You must have some good news.
Here we go. I'll cheers to that.
There you go. Yeah, I guarantee, Susie, you will never get prostate cancer if you drink that coffee. That's it. That I'm 100% sure of.
I believe you.
There's not much that's certain in this world, but that one is.
For certain, yes.
So dairy is another one. Increased dairy consumption, particularly full cream dairy, is associated with higher all-cause mortality, cardiovascular, as well as kidney disease and other gastrointestinal disease, and also prostate cancer. So dairy in moderation, and often go for the low fat if you want to. The low fat is not a significant improvement. It's more about reducing your overall dairy consumption. So your creams, your butters, your yogurts, your milk, and the adding of those. So if you drink your coffee, but it will be healthier black for your prostate. Anti-inflammatory nutrition, really critical, because so many health states, and prostate cancer is one of them, aggravated or promoted once established by an inflammatory environment. And there are lots of foods that are inflammation general. I'm talking global body inflammation, not local injury inflammation. So poor choices would be processed meats, so your salamis, pepperonis, pizza, meat, bacon, etc. So where the meat is being processed, sugary drinks, absolute disaster. So sodas and pop and anything that's got sugar in it, and it has a lot of sugar in it. Trans fats or fried foods, certainly a worry. So these are foods that generate inflammation, white breads and pastas. And the better choices, funnily enough, fruit and vegetables. Who would have thought?
Go figure.
Yeah.
As they say, garbage in, garbage out. So
one of the biggest surprises to these guys, I tell them that your prostate is not as old as you are. They say, what? I said, no, you're born with a prostate. Yes, I know that, but it's not as old as you, because your prostate cells have been replaced through your lifetime. They don't live forever. They die off and you rebuild them. You die off and you rebuild them. So your prostate cells are probably only, at best, 5 years old. So, but they have been rebuilt based on what you eat.
Your environment.
You can only rebuild with the ingredients you put on board. So the better your quality of nutrition, the better your building products are for replacing all the cells in your body, which is happening every day, millions at a time. So cruciferous vegetables are really important. They're the ones that that everyone loves: broccoli, cauliflowers, bok, cabbage, Brussels sprouts, all of those. They are better than ordinary vegetables. They are the super vegetables for prostate cancer, cruciferous group, the ones that have a cross in their flower structure. beans, lentils, avocado, coconut, walnuts, pistachios, and the best nut of all, Brazil nuts. Mm-hmm. Brazil nuts are high in lots of things. They're anti-inflammatory. They've got lots of things in there that are really prostate cancer suppressing. So a handful of those every day doesn't go astray either. So cold water fish, red meat in moderation, okay, but do not cremate it. It must not be grilled to well done because it's the carbonization of the meat that makes it carcinogenic. So if you eat red meat, and no more than once or twice a week, rare to medium. Medium rare is okay. Medium, you're starting to push it, but enjoy your meat, but buy better quality and don't cook the stuffing out of it. Smaller amounts, yeah. So there are lots of things, and this is all in this new book, all the nutrition advice based on research. And then the final section is on physical activity. It's on what you do.
Yeah.
So we look at walking, we look at weight training, resistance training, cardiovascular training, yoga, tai chi again. So, and ejaculation as a physical activity.
Yes.
As to detoxify your prostate gland. So this is basically, as I said, it's a playbook. It's a strategic manual for men who want to avoid prostate cancer or the treatment for prostate cancer.
That's beautiful.
And they're a bit neglected. Now, this is not rocket science.
Right.
It's exactly what their mothers told them. Eat your fruit and vegetables, drink your water, go out and play.
That's
all the good messages you have when you're a kid. But when you grow up, you lose that. Yeah. And you make your own decisions. And in a lot of ways, the smart decisions.
That's right.
Prostate cancer is the end game of all the decisions you ever made.
That's right. Oh, Craig, this has been so amazing. And I'm sure our listeners are just in awe of the wisdom that you just dropped here on our conversation. So how can they connect with you if they wanted to learn more?
Sure. The Prostate Recovery Map website, www.prostaterecoverymap.com. All small case, one word, one long, 3 words packed in together is good. I also have a personal website, craigallingham.com, and you can move that on to other sites from there. So I also cover other enterprises as well. But that's for men's health. Yeah, start there. That'll be good. The book is available online. The book is available in the UK, yeah, I think so. It's online. It's available everywhere. Everywhere we do have it available in the States as well through Amazon.
That's right. Yes. That's where I get it.
Okay.
Awesome.
Yes, yeah, good. And the new one will go the same way. It'll be online first, and it's in all the bookshops, in Australia and New Zealand, but it's hard to get distributorship rights beyond that at this stage. But it's a huge market. 17,000 new diagnoses this year in Australia alone. I hate to think what it's going to be in the States. Every one of those men is either going to have treatment and require the Recovery Map book. That will help. It doesn't require it. They may have good care elsewhere, but it might help. And those that choose not to have treatment yet, defer or avoid treatment, they'll benefit from the other book. So I'm trying to cover these guys so that they have got a go-to resource at home that they can flick through. They're only short, 60, 80 pages. There's some jokes in there. There's some pictures. It's not too hard to read, men. All right?
No, it's not, guys. It's a great read, and it is a recommended, required read for my patients that I'm working with who are going through something like this. So honestly,
that's wonderful to hear.
It has been a wonderful resource. And again, Craig, I can't thank you enough for your wisdom and your witty humor. And it was such a great conversation. And I'm sure that will help many, many men and their spouses and their friends and their fathers and their sons to many years to come. So thank you so much, Craig, for again being on the show today. We really appreciate it.
Thank you for this opportunity, Susie. It's been a delight.
Thank you.
Thanks for listening to today's episode. Be sure to head on over to drsuzyg.com where you can get more information, show notes, and related articles on today's topic. Also, if you like what you're hearing, head on over to iTunes, subscribe to the podcast, and leave us a rating and review. We'd love to hear your feedback. Thanks again.
Here we go. I'll cheers to that.
There you go.